स्क्रीन शेयरिंग वगैरह वो कटेला ना वो कहाँ करो पावर पॉइंट स्क्रीन शेयर कंटेंट करो
वरदाय सुरः प्रियाय लंबोदराय सकलाय जगद्धिताय नागाननाय श्रुतियज्ञ विभूषिताय गौरीसुताय गणनाथ नमो नमस्ते कर्पूर गौरम करुणावतारम संसार सारम भुजगेन्द्रहारम सदा वसंतम हृदयारविंदे भवं भवानी सहितं नमामि। सर्वमंगलमांगल्ये शिवे सर्वार्थ साधिके शरण्ये त्र्यंबके गौरी नारायणी नमोस्तुते। या कुंदेन्दु तुषार हार धवला या शुभ्रवस्त्रावृता या वीणा वरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्मा च्युत शंकर प्रभृतिभिः देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा आविर्बभूव कलशं दधतर्णवाद्यः पीयूषपूर्ण ममरात्वकृते सुराणां रोग्जालजीर्ण जनताजनितः प्रशंसो धन्वन्तरि च भगवान् भविकाय भूयात्। ओम शांति ओम शांति ओम शांति। After praying my Lord Shiva and Lord Dhanvantari along with Goddess Durga, now I would like to welcome all experts, Kalpesh, Aditya, all experts in the audience. Welcome to Imami Jhandu National Webinar, Ayush Samriddhi. Now Dr. Aditya.
Yes, sir. मैं धन्यवाद देता हूं डॉक्टर पवन कुमार शर्मा जी का। और ईश्वर स्तुति के बाद में मैं सबसे पहले अपने जो प्रस्तुति करूंगा उसमें भगवान धन्वंतरी को याद करते हुए अपने प्रेजेंटेशन को आगे बढ़ाऊंगा। Screen is visible, sir? Screen is visible?
Yes, yes.
Right, sir. coming, sir, properly.
Share the screen. Share content. Share content. Screen 1. Yesterday you have done
Yes,
this.
sir. Already done, but screen is not clear.
ऑल कंटेंट शेयर करना है नहीं पहले है ना
Already done.
मैंने कई वन टाइम शेयर कंटेंट कर
Are you able to see the screen, Dr. Kalpesh? Sharma sir, screen is visible.
Yes, yes, yes.
Okay.
Slideshow.
Yes, sir. सर्वप्रथम मैं भगवान धन्वंतरी को स्मरण करते हुए सरस्वती वंदना करते हुए आगे बढ़ूंगा। ओम नमामि धन्वंतरी आदि देवम सुरासुरे वंदित पाद पद्मम लोके जरा रुद्भय मृत्युनाशम दाता रमेशम विदुषनाम धन्वंतरी समानाथम सर्वलोक निवारकम आयुर्वेद प्रवक्ता नाम वंदे पीयूषदायकम। ओम शांति 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 ही। ओम सरस्वती नमस्तुभ्यं वरदे काम रूपिणे विद्यारंभम करिष्यामि सिद्धि भवतु मे सदा। Today, the topic of discussion is breast cancer screening and Ayurveda management, and along with me, my colleague Dr. Kalpesh Chajad is there for the discussion of oral cancer diagnosis and management. और जैसा कि हम सबको मालूम है कि कैंसर जो है कि WHO के आंकड़े अगर हम देखें, cardiovascular disease is the number one and second non-communicable disease, and cause of death are cancer. And behind that, yesterday we had a discussion regarding the topic obesity is the one among the causative factor. With this, I proceed to the next slides. As per the WHO, the breast cancer new cases in the India approximately 27%, and total number of cancers reported in the 2018 in India were 5,87,249, and the other cancers were 2,05,971. And the second one, we just see the contribution is of cervix uterine cancer, that is 16%, ovary cancer, that is 6.2%, lip oral cavity cancers contribute 4.8%, and other cancers, stomach, lung, colorectal cancers are also the causes. And we see the estimate number of deaths in the year 2018, all the cancers in the female of different age groups. The breast considered to be, you can see that 23.5% is the contribution for the death rate in India. And the second one is 16.2%, ovaries cancer, that is 6.5%, oral lip cavities 5.9%, and the total number we see 3,71,302. These are the data has been taken from the WHO. And anatomy of breast, we all have just studied in our first year, that nipple allulars, lactoferous ducts, breast lobules, fat tissues, that already we have studied. And there are different causative factors and different modifiable risk factors and non-modifiable risk factors for the breast cancer. The first one, the obesity, which the topic we have taken yesterday, that obesity is the causative factor behind the cancers, and we all know the reasons of obesity are of wrong diet habits and wrong lifestyle. Also, the different types of pills and also tobacco in the form and drinks also and breastfeedings. These are the things can be help to modify the risk factors in the breast cancer. And moreover, the causative factors has been divided into the two categories. First one is endogenous and other one is exogenous. Endogenous are nulliparity, age at menarche, ages, menopause, family history, and the different we see the exogenous risk factors are alcoholic consumption, obesity, dietary factors, chemical carcinogens. All these are the different causative factors. And non-modifiable risk factors, also we know that cancer, female are the more prone to have the breast cancers, and menopausal is also one among that reason. Family history, menarche, and DNA also one among that positive factors, non-modifiable risk factors. And if we see the changes in the breast shape and size, that in Acharya they have clearly mentioned that दर्शनम परीक्षा स्पर्शनम प्रश्नम त्रिविध परीक्षा, ये जो सारी हम चर्चा करेंगे, जो आचार्यों ने हमारे को 5000 साल पहले ही जो ये ज्ञान दिया है आयुर्वेद का, उसी माध्यम पे ये जो मैं आगे चर्चा बढ़ा रहा हूँ, इसके अंदर हम देखेंगे कि दर्शनम परीक्षा, प्रश्नम और स्पर्श, इस त्रिविध परीक्षा के अंतर्गत ही हमारे सारा जो डायग्नोसिस ऑफ ब्रेस्ट कैंसर वो सारा आधारित है. जो हम देख रहे हैं कि चेंजेस इन द shape or the size of the breast by darshanam pariksha only it can be just noted down, and any painful or painless lump in the breast is also be can be seen and can be noticed. And also that nipple discharge is there, or a reddishness of skin or nipple retraction is also the can be observed by the darshanam pariksha. And most important that changes in the skin and the orange peel appearance. The surface of the breast just appears similar to the orange peel, and dimpling of the skin is also inspected by darshanam, and swelling in the armpit is also one among that factor. Ulcerative mass, the non-healing ulcers may lead to the next level of the cancers, or just to avoid that, initially it has to be inspected and treatment should be started. Pain in the breast is also a sign or a symptom, say. And moreover, if we see all in this slide, we see that there are different categories. We can see the sign and symptoms, the feeling of thickened area, dimpling of the skin or the lumps, growing veins, shrunken nipples, new shape and size, orange peeled skin, hard lump, unexpected fluid discharge, or reddish or hot on the sparsham pariksha. We can see nipple crust. All these are the different kinds of changes in the shape and the size, and that we see some of the other form of the fluid discharge or the pus discharge or the serous discharge can be seen in these cases. And modalities of early diagnosis, most important that before going to the treatment, the early diagnosis plays an important role in the treatment part. And it starts with the patient itself only, and self breast examination plays an important role in the treatment diagnosis of that breast cancer. And the clinical breast examination, which is performed by the experts. And if we see in the first that female has to be just in the front of the mirror and looking at both the breast. That is by seeing only is there any change in the size or the shape of their breast. And the second, we see that by raising both the hands, is there any change in the sign, shape or the size of the breast. And third one step is that by lying down and just with the three fingers, with make the pad with the three fingers, and it has to be palpated, and it has to be seen that in the circular movement or towards the out movement on the surface of the breast, that should be thoroughly checked. And also, just I just told earlier only that by darshanam pariksha, by only this is the first darshanam pariksha which Acharya Charak, Shushruta and Vagbhata in different contexts they have just already told for the diagnosis of any disease and imaging. That is ultrasonography and mammography plays an important role in the diagnosis of the breast cancer. And fine needle aspiration cytology, just by taking the fluid of that lump and check whether the cancer cells are there or not, it has to be inspected. And the first initially that is should be started with that self examination. Second step is if they found any lump or anything is there, then the patient should be asked for that ultrasonography or the mammography. And if anything is suspicious, they has to be advised for the fine needle aspiration cytology. And moreover, for the further investigation, core biopsy has been done or the ultrasounded biopsy has been done for the confirmation of that malignancy. Triple assessment. Modern science also talk about the triple assessment for the breast examination, which acharyas have already told, Trivid Pariksha. I'm again and again just focusing on Trivid Pariksha and the triple assessment by just taking the proper medical history that the expert is just palpating and checking the breast, that is the Sparshnam Chikitsa, ultrasound, mammography, fine needle aspiration, and also core biopsy has been done for the investigation and the confirmation of the malignancy. And there are also some steps for the prevention of the breast cancers. We can see that weight management, that should be important criteria for the avoiding or prevention of the breast cancer. Regular exercises, proper diet should be taken, and say no to tobacco, धूम्रपान, मद्यपान, चायपान, मांसाहार, इन चीज़ों का सेवन नहीं करना चाहिए. और कहीं ना कहीं हम देखें कि रिड्यूसिंग रेडिएशन आज के टाइम में ब्रह्मांड में जहाँ पे भी हम देखते हैं पूरे यूनिवर्स में व्यक्ति कहीं ना कहीं रेडिएशन से शिकार है. जेब के अंदर मोबाइल है या मोबाइल टावर्स लगे हुए हैं या कहीं ना कहीं हॉस्पिटल भी विजिट करते हैं तो कहीं ना कहीं रेडिएशंस के शिकार होते हैं. तो ये भी एक कारण रहता है. तो इससे भी हमें बचना चाहिए. अगर हम अपने वर्क प्लेस पे हैं या ड्राइव कर रहे हैं, मोबाइल को अपने से दूर रखा जा सकता है. एंड ऑल्सो बाय जस्ट darshanam pariksha, by self examination, patient can have the self examination for the breast, and if they found anything they can consult with the doctor. Breast self examination is an important part or an important tool, I can say, for the diagnosis of the breast cancer. That so don't wait till it is late. So it should not be wait or delayed in any condition. And so the breast self examinations, there are some few steps. I will just talk about that. There are basically 5 steps for the breast self examination. The first step, which I have already explained, looking in the mirror with shoulders and straight arm on the hip, and is there any change in the shape, size, or the color, or nipple, alveolar, dimpling or puncturing, or any discharge is there, or any pus is there, that should be seen. And the second step is raising the arms and looking for retraction or indrawing of the nipples. In that second step, retraction and indrawing of nipples has to be checked. Dimpling of the skin should be seen. And the third step is gently rolling the nipples between the fingers and the thumb and check nipple discharge or blood discharge or any kind of water discharge is there. This is the third step for the inspection. And the fourth step is by lying down and just making three fingers as a pad for the examination. And by lying down, we just with these three fingers we check in the circular movements. In the line forms we can check out on the surface of the breast and the wedges, and the clockwise it has to be checked properly, thoroughly, whether is there any lump or any kind of changes is there. And lying down, feeling on the back is also should be seen, and also on your sideways also should be seen. Most important part is that who should perform the breast examination. Here some certain guidelines have been given that all the women above 20 years should just have a breast self examination. And when that's a most important part, then when it should be seen in the menopausal females or menopausal women, it should be seen in the fixed day in a month, or in a menstruating woman it should be seen after 5 to 7 days. Basically, it's 7 days after the periods is been advised for the breast self examination. So both the guidelines have been given for the menopausal woman as well as for the menstruating woman. And important part is that prevention is better than cure. Everybody knows that the prevention, nobody wants to be in the trouble whether it's reached to the advanced stages of the cancer. And I will just talk about the management part. So management part, there are different medicines part. We see talk about medical oncology, radiation oncology, oncology nutrition, psycho-oncology. These are the different types of treatment or advice by the medical sciences, and it should be with the teamwork only it is been taken care for the breast management. So I will just talk about the treatment of breast with Ayurveda. So I will be just talking on the treatment with the Ayurvedic aspects. And most important thing is that many of them experts, and also many of them customers, many of them patients, they have many kind of questions, many kinds of I can say that they are not about clear about the facts. They think that it's Ayurveda is a magical cure for the cancer. But my dear friends, I will just say from this platform, Ayurveda is a science of life. It is not a magical cure. It's a science of life. There are scopes and limitations for the treatment. If it has to be properly just inspect and properly diagnosed, and the treatment has been advised by our Charak, Shushrut and Vagbhata in different parts of their sthanas. And so I am very much confident and clear about my Acharya's reference, which has been given 5,000 years ago. No magical cure. So they have categorized the disease. The first one, they have talked about the sadhya, the disease which can be cured easily. They have already categorized the disease which can be easily by the medications. First category is that, and second category, all we know that krit sadhya, the disease which can be cured after hard efforts or with the help of the panchkarma therapies and the other procedures. Panchkarma, Vaman, Virecha, Niru, Nasya, and Raktam, all these detoxification therapies are being advised for the krit sadhya rogas. And yapya are the yogas, the disease which cannot be cured but can be maintained यथास्थिति. अगर किसी रोग की हम यथास्थिति बना के रखें तो वो भी एक अचीवमेंट है. इसके लिए वो रोग बढ़े भी ना, इसके लिए भी आचार्यों ने 5000 साल पहले इसका वर्णन किया है और बताया है कि कुछ औषधियों के माध्यम से, पंचकर्मा के माध्यम से और सर्जरी के माध्यम से हम रोग को रोक सकते हैं। और एक कैटेगरी जो आचार्यों ने क्लियर कट कहा है, असाध्य, द डिजीज विच कैन नॉट बी क्योर्ड. So the physician should be very much clever, very much intelligent in diagnosis of the disease. If his diagnosis is perfect, he can treat that cases in a proper manner with a confidence and give a confident to the patient and patient family members about the different diseases. And next, I will just talk about the Ayurveda. They are according to the doshas. We are just treating according Vat, Pitta, Kapha doshas, and what is the Pradhana dosha is there. Accordingly, we are just treating, and inflammation is there, and pain, heat, santapa, reddishness, swelling. According to that symptoms, any shofa, whether it's due to the Vataja, Kaphaja, Pittaja, or Abhikataja, Raktaja, what are the different categories for the Shofaja? It has to be properly inspected. And in our Ayurveda, it has been clearly mentioned Granthi, that are the basically benign granular swellings, and Arbuda, they are clearly definitely a malignancies. And they have been compared with some sarcomas, Mams Arbuda, Rat Arbuda, that are oral cancer, which my friend Dr. Kalpesh Chhajar will talk about, Mukha Arbuda, oral cancers, and also that different categories of the heart tumors, Karkat Arbuda, Adhaya Arbuda, primary metastasis, ulcerative tumors, Varna Arbuda. These are the different acharyas have already explained. We just keeping this all things in the mind, and if we are treating with the sign and symptoms according to the Desh, Kal, Ayu, Bal, then we are getting, and confidently we are going to treat that patient and make the quality of life of that patient very good. And also these are the some Ayurveda and the cancers, some modern comparison, some of that things, Apache, Hodgson, and Stanna Roga, that are cancer of the breast, Yakritodara hepatomegaly due to the liver metastasis, Plehodara splenomegaly due to the inflammation of the spleen, Rakta Gulma, tumors of the uterus and the ovaries, and also some of the Sarvamanga tumors of the larynx, and also carcinoma of the palate, carcinoma of the lips. They are already acharyas have explained about them. And I will be just talking specifically about the Ayurvedic line of treatment for the cancer and any other cancers which have been just explained. So management is very much clear. The main objective of the Ayurveda is to just swasthya ojas karam, to improve the immune system of the patient, or is vikar prashmanam. That is the important part, main objective of the Ayurveda, just to have a giving to the patient. And the treatment protocol which are being advised by the acharyas are the surgery, various procedures like Snehan, Swedan, Vaman, Virechan, Nasir, Basti, Shar Karma, Rakt Mokshram, and also Shamana Chikitsa, Harbo Mineral, and also metallic, zinc, copper, all our Rush Oshadis are the different categories are being just advised by the acharyas for the treatment of their cancer. Are the same symptomatic relief. We can say that cancer patient, if there any pain is there, so all the types of Google preparation are advised for the pain relief. Example, we can say that Kanchanar Google, Keshore Google, Amrit Adi Google. According to the dosh of that patient, we can advise Google. And is there any symptoms of nausea and vomiting? Soothshekar, Shatavari, all these are advisable. Shatavari is also one among the rasayan. So it can be given in the disease condition also, and also to improve the quality of that life of a patient. Shatavari is also advisable. And recurrent infection, Gandak rasayan, loose motions, we have Bilva, Mayur picture, Kutaja, Adivati, we can advise. An abdominal pain, Shankh Vati, Am Pachan Vati, Chitrakadi Vati are also advisable. and also pain in the renal colic pain, Katuki, Rohitika, all these drugs are advised for getting the relief, symptomatic reliefs. Because during that treatment, patient is taking any kind of chemotherapy, radiotherapy, or any kind of surgery a patient is undergoing, because we cannot say that a specific line of treatment will work for the patient. For a cancer patient, proper diagnosis should be done. After that, if it's required a surgery, then a surgeon should do a proper surgery. If it's required a chemotherapy or a radiotherapy for the patient, it should be advisable. But along with that, totally dependent upon that, will not get the relief to the patient, but somehow the symptomatic relief should be. And also to improve the quality of life, that Acharya has told that Ayurveda should be admitted, and the total to avoid the further metastasis, the Ayurveda medicine has to be advised. In the cases of jaundice and the back pain, ashwagandha telam and also Googles are also advisable. So there are also some of the adjoints or the co-therapy with the that we can say that radiotherapy or the chemotherapy. So if a patient is going under radiotherapy and chemotherapy, we all know that there are some of the other side effects, definitely nausea, vomiting, fever, also some kind of lethargicness, fatigueness, a loss of taste. All these symptoms are being developed during the treatment. So many of the patients withdraw the treatment. They cannot continue with the treatment. So main important point is here of discussion is to improve the immune system of that patient, quality of the patient. These medicines are have to be administered like Trifla Rasayan, Chanprash, Amlaki Rasayan, Amrit Rasayan, Brahm Rasayan, Kamdukta Rasa, Lakshmi Vilas Ras, and Makar Dhwajvati, and many more. Swan Vasan Malti, Swan Basam, Hirak Basam also plays an important role in the treatment of that cancer, any kind of cancer, especially breast cancer. Also, there are different categories. It has to be selected according to the dosh and ayu of that patient. So we have talked about the medicines part, or the chemotherapy, radiotherapy, medical oncology, and psycho-oncology is the most important part. If any patient comes to know about the cancer, so that question or that report with the doctors, definitely, if he answers anything, it will definitely change the life of that patient and also the uh, life of that relatives, family members also. It is not only the change in the life of that patient only, it will change the of all the relatives and the patients also, moreover the family members also. So giving a bad news is also a professional practices, but that has to be taken care, how it has to be just told to that patient, in which manner, that is also a very important skill. Because many of them how they react after knowing that diagnosis. So there's some few steps how to communicate the bad news to the patient. So communicating one message at a time. So it can be advised to communicate only one message, build some of the confidence, and wait for the response. Once you have told anything to the patient or with the reports, what's there in the report, if patient asks, डॉक्टर साहब रिपोर्ट में क्या आया, मेरी बायोप्सी रिपोर्ट में क्या है, या ब्लड रिपोर्ट इन्वेस्टिगेशंस में क्या है, आगे आप क्या जांच कराएंगे, तो बहुत ही तरीके से उस मैनर में डील करना है. एक चिकित्सक का बहुत ही इंपॉर्टेंट रोल है, जो साइको एक्सपर्ट्स है उनका बहुत इंपॉर्टेंट रोल है, फिजिशियन का बहुत इंपॉर्टेंट रोल है. And also that has to be keep in the mind, do not answer direct question, because if once you have just anything to the patient, there a lot of questions will be there in his mind कि ये मेरे को ही क्यों हुआ, मैंने जीवन में कभी धूम्रपान नहीं किया, मद्यपान नहीं किया, तो मेरे को ही क्यों हुआ. इस प्रकार के क्वेश्चंस वो करेंगे. कई बारी नाराज भी होते हैं, कई बारी एग्रेसिव भी हो जाता है पेशेंट. तो हमें उस सिचुएशन में साइलेंटली वॉच करना है एंड डू नॉट answer direct questions to that patients. So you can just have a proper communication with the patient. And here are some factors which can help to reduce the risk factors in the breast cancers that I have already discussed about the breast self-examination. Breast self-examination is the first basic thing that all the females should be examined above the age of 20 years. And at the menopausal, that should be fixed day in a month, it has to be seen. So धूम्रपान, मद्यपान और अपना वजन ना बढ़ने दिया जाना चाहिए और रेगुलरली फिजिकली एक्टिव रहना, फ्रूट्स एंड वेजिटेबल्स एंड ब्रेस्ट फीडिंग इज आल्सो helps to reduce the risk factor of the breast cancer. And also cancer therapy is basically a co-therapy, so we cannot say that only a single therapy will work for the patient. It has to be planned at the each and every step of that patient's life. Once the patient have diagnosed and different was the selection of the treatment, so it should not be, and a physician should not be rigid or should be very much confident. He should minutely see whether Shravan chikitsa is required or purification Shodhan chikitsa is required, or oral medication, detoxification, rejuvenating drugs are required, or surgical management is required. Because some of the cases chemotherapy works, some of the radiotherapy works, and where surgery is required, surgery has to be done. And I will talk about this Ayurvedic juice. Our Acharya has very well explained that yantra nishpidite rasa sarvasa iti uchyate. That means that Swaras Chikitsa is the most important part. So I am sharing this few of this in my practice or my past experience. I have been sharing which given to of my some of my patients, and definitely what some of my observation was there. So this is the ingredients of the juice. I have read it in many articles, many my seniors, my I can say that Aptavachan, we can say that Aptavachan, which we have read, or our Samhitas, our seniors, that Gyan which have acquired from them or with the different references, which I have implemented to some of my patients, and which I have found that beetroot, lemon, tomato, palak, gajar, amla, giloy, podina, wheatgrass, turmeric, all these ingredients, all if we prepare a juice that basically with all these ingredients helps the patient with the just maintaining the good hemoglobin level, also helps in the digestion, also source of vitamins, also antioxidant, source of antioxidant, and also immuno boosters. And also turmeric, we see that कच्ची हल्दी को अगर हम इसका प्रयोग करते हैं, हमने कई जगह पढ़ा है, आचार्यों ने हमें देखा है कि दादी या नानी के जो फॉर्मूले में हम सुनते आ रहे हैं बचपन से, लेकिन हम जाने अनजाने में इस्तेमाल करते भी हैं, नहीं भी करते, एक नेग्लिजेंसी पार्ट में रखते हैं। लेकिन ये मैं पूरे विश्वास के साथ कह सकता हूं कि कच्ची हल्दी, आंवला, गाजर, बीटरूट और लेमन, टमाटो, पालक, इन चीजों का अगर हम प्रयोग करते हैं, लेकिन सबसे इम्पोर्टेंट चीज है कि हमें हर एक पेशेंट को नहीं देना, ऐसा नहीं है। अगर मान लीजिए किसी व्यक्ति के ऑलरेडी लूज मोशन है, ऑलरेडी डायरिया है, इफ वी गिव दिस इंग्रेडिएंट्स, सो it will be just a contraindication in that situation. So I already told it should be properly diagnosed, then only it has to be given. So all keeping things in the mind, then only we have to give this juices, and accordingly we have to increase or change the ingredients. But this formula I have tried on, and with my patients feedback I am just sharing this. It is wonderful for the hemoglobin. Many of the patients undergo the chemotherapy, gradually their hemoglobin level just fall down, but after they have to go for the next chemo, so we see that they have to take some of the injection, or even doctors advise them to just avoid their chemotherapy because of not proper hemoglobin levels. So these are also the helpful in that conditions. And there are many foods: cauliflower, Spanish nuts, broccoli, tomato, many food fighting foods for the cancers we have read. So I think green tea is also helpful in that condition. And the breast cancer line of treatment, our acharyas have very well explained that Shodhan, Shamna, Rasayan, Chikitsa, Ahara, Satvaja, Dev, Pasha, Yoga, Pranayam. So it is not only the one thing, only surgery. If we have done any surgery to the patient, that he will be fit and fine for the throughout the life. It's not there. So we have to be a teamwork. It's there. It has to be taken care. Family support should be there. Financial support should also be there with their families and from their relative sides also, and also Shamana Chikitsa, Shodhana Chikitsa, Rasayan Chikitsa. So it depends upon only the Vaidya or the physician. Line of treatment has to be worked. But I'm confident that Sattvaja, intellectual or the mind, once the patient comes to know about the cancer, so important thing is that he has to be just made the things to be clear, then only the treatment should be started, because the treatment, 80% of the treatment is been done psychologically. Because if the patient accepts that situation and ready to face it with the confidence, then definitely doctor will have the confidence and to have the diagnosis and the proper treatment for that part. If already we have just seen the Veshadravya Upasthita Rogi Pachadosham. So the Vedya is intelligent, confident, and patient role and responsibilities as advised by the acharyas should be taken care, and Aushadhi should be just very selectively has to be taken in the breast cancer line of treatment. So all these are the factors, and also yoga and pranayama is also an important part of the treatment. So it's not that only just giving the Ayurvedic medicines or some modern medicines that the patient will be throughout. So psychologically, he should be just very much fit and fine for that situation. Yoga and pranayam will just make him uh, uh, calm down, and also that hormonal changes, adrenaline, non-adrenaline types of hormone are released during this phase, so it will help to maintain that levels also. And pleasing God, सो इट इज ऑल्सो एन इम्पॉर्टेंट पार्ट कि हम भगवान का स्मरण करना भी बहुत ज़रूरी है, क्योंकि हमारे पास में इम्यूनिटी के लिए बहुत कुछ मिल जाएगा. हमारे पास में कीमोथेरेपी मिल जाएगी, रेडियोथेरेपी मिल जाएगा, सर्जरी करने के लिए मिल जाएगा, लेकिन जो आत्मविश्वास का जो कैप्सूल है वो मार्केट में कहीं नहीं मिलेगा. किसी चिकित्सक के पास में नहीं होगा, किसी केमिस्ट के पास नहीं होगा, कहीं पे भी नहीं मिलेगा. ये केवल और केवल हम स्मरण करेंगे, जो आत्मविश्वास आएगा वो ही ट्रीटमेंट का एक माध्यम बनेगा और आगे चल करके उसको इस रोग से मुक्ति दिलाएगा. Many over the things are the breast cancer, Ayurvedic herbs are there, yogas are there, and different herbs as advised by the acharyas, that Shudshekaras, Punavad, Mandur, Arogyavadni, Apattikar Churan. All these are the, I can say that the drug of choice for the treatment of the breast cancer. Hirak Basam, Gojivadi, Chincha, Barlataka, Samir Pannagras, and single herbs, Devdaru, Varuna, Bala, Ati Bala. These are the Karkuma, Shalaki, Arjuna. All these has to be selected by the Vaidya according to the situation. And quartz and the purification according to the Ayurveda, Varunadi Quat, Panchvalkal Quat, Manjishtadi Quat, Dashmula Quat, Kanchanar Quat, these are also been advised for the purification of the body. And this is the management and the symptoms before, during, and after the treatment. If we see the patient of a cancer patient, there are some of the other sign of symptoms. So here are the some categories which I have worked on that. So group A is that Ayurvedic medicine, B are the herbs, C fruits, and D are the vegetables. So all these here we in the left side of the screen we see that vomiting, constipation, immunity, mucositis, dryness of the mouth. These are the one or two I've shared, but there are a lot of many other things. But most important things that these, what is how it has to be just evaluated. So I have mentioned PGSGA, patient generated subjective global assessment. हमारे आचार्यों ने 5000 साल पहले ये सारी बातें कह दी, सारी चीजें लिख दिया है, लेकिन कहीं ना कहीं समाज में भ्रांति भी है, कहीं ना कहीं आत्मविश्वास भी खोते हैं। तो लेकिन हम देखते हैं कि कहीं ना कहीं जो एक ये मॉडर्न टूल है, जो कि इसके आधार पे कैंसर के जितने भी जो रिसर्चेज होते हैं, जिसको हम कहते हैं पेशेंट जनरेटेड सब्जेक्टिव ग्लोबल असेसमेंट, इसके आधार पे ही एक ये रिसर्च है जो कि ये पूरा प्रॉपरली बताएगा कि इसके ऊपर भी काम चल रहा है। और इससे मैं आपको ये बताना चाहूंगा कि ये कहीं ना कहीं ये काम करते हैं। And the general treatments already I have discussed with all of you, my friends. And detoxification therapies, Shamshodhana, detoxification, Upanaha, Swedanaha, parasurgical Raktamokshanam, surgical excision, parasurgical approaches, bloodletting, all are different types of treatment. But most important part is that the patient has to be taken care of all the aspects. It is not to only a single aspect. Psychotherapy, that yagna should be performed, chanting of mantras, bhakti yoga, meditations, yoga, asana, mudras, pranayamas. This should also plays an important role in the treatment of the cancer. It is not only a single therapy will work. I have again and again repeating that in cancer therapy, not a single drug will help. All the aspects should be checked properly, what's going in the mind of the patient, what actually requires at that moment. So a physician should thoroughly take the history of that patient, then only administer all the things. With all the things, I will once again I will just summarize of my presentation that Panchkarma therapy will also helpful, single herbs will helpful, psychotherapy will helpful, medical oncology, radical oncology will work on that, and also the different yagna, psychotherapy, mantra chanting, all will help out. And most important, today we have my friend Dr. Kalpesh Shajar is there, is going to discuss about the oral cancer. So he will be just talking about surgeries and everything. So that is also we all know that the father of surgery is Shushrut. The father of surgery is Shushrut, and I can say that is Dr. Kalpesh is a Shishya of Shushrut, and after my presentation, he's going to carry forward the presentation with some of the tips I just share with my friends. Nutrition recommendations for the breast cancer survivors. That brisk walk, 30 minutes brisk walk should be advisable. Healthy weight should be maintained. If a patient has already taken all the treatment in the survivors of the cancer, avoiding non-vegetarian diet and calcium supplements properly should be taken, vitamin D and quat, green tea, and nutrition should be taken in the form of food, not in the form of phytochemicals or any form of supplements. And with this thing, I thank to all my viewers, and thanks to Dr. Sharma sir for giving me the opportunity. Thank you. And with today, my friend Dr. Kalpesh Shajar is there, so he will be just sharing.
Excellent, excellent, Dr. Aditya. Great.
Thank you, sir. Thank you.
Beautifully explained in general language. Nice, nice, nice.
Thank you. Thank you, sir.
Now I would like to invite Dr. Kalpesh.
Yeah, thank you. Thank you, sir. शेयर करना है, शेयर नहीं किया कंटेंट। शेयर मत। Sir, can you see my screen, sir? Visible, sir?
Yes, yes, visible. You can go for slideshow.
Yes, sir.
Slideshow.
Go for slideshow.
Yeah, is it visible
Yes.
now?
Nice.
Okay, okay. Thank you, my dear friend Aditya, for you have done most of my job by describing a lot of things which I was supposed to describe in my presentation also. So you have done a lot of things from my end also, and reduced my work. And first of all, I will like to thank Imami Group, a renowned brand in Ayurvedic products, our today's moderator and vice president of Imami Group, Dr. Pawan Kumar Sharma sir, and my dear friend Aditya, for giving me opportunity to talk in front of this group, and to present something in very unique platform of Ayush Samriddhi. So good evening, all respected seniors and my dear friends. Today I will discuss how oral cancer is diagnosed and how it is managed in a way so that we can give a better quality of life to our patients. So here, sir, dear friends, already Dr. Aditya has told any, be it be an oral cancer or any other cancer of the body, it is not a one person's job for its treatment. So it is a multidisciplinary team approach. So likewise, oral cancer is also a multidisciplinary team approach. And I always tell, before any consultants who are operating or doing radiation work, chemotherapy, or any other form of treatment, the first and foremost important person in the cancer management are general practitioners, be it be any homeopathy doctor or Ayurvedic doctor, any MBBS person or any general practitioners. They are like neutrophils. We would have heard neutrophils are the first line of defense. So they are the one who diagnose these things properly. So it becomes the responsibility of the general practitioners to know how to diagnose these things properly. So there should be no problem related to the diagnosis of these conditions when we have to see like precancerous lesion like leukoplakia, erythroplakia, or if there are any malignancies or there are any other tumors in the oral cavity or something. So they should be properly able to diagnose that. So if I will explain with a simple example, like if there is a decay in the tooth, so it can be filled easily. If decay expands little bit more, then that tooth can be saved with root canal treatment. And if decay processes still further, then what will happen? We need to knock out the tooth. So same thing happen in the oral cavity cancer. We don't want patient to report in this stage. And this is a clear example on the part of patient's ignorance, because see, this patient I have seen during my training, when the patient was in the stage one, then later after 1 year they reported with this. So we don't want such delay on the part of the patient or anything. So by just detecting the dental caries, you can save a tooth, but detecting the cancer patient at an early stage, you can save a family. Not only the patient, you can save a family. So Dr. Aditya has already told about the various cancers, how it is rapidly spreading, and there are almost 1 lakh plus cases reported annually in India itself, um, according to the recent data. And if you see the cancer-related death of the oral cavity cancer-related death, India tops in uh, is at the number 3 in cancer, oral cancer-related death. If we see the burden of oral cancer in India, in the different part of the India, there are the states or there are the places where a lot of burden of cancer is there. So I practice in Ahmedabad, and it is considered as one of the cancer capital of the India. So a lot of cases are reported in the Ahmedabad. So in the western region of the India, if I consider, then it is Ahmedabad. In the south, it is Chennai. In the north side, it is Delhi, from where my dear friend belong. And in the central part, it is Bhopal. Why the importance? Why we need to stress on the early treatment or early staging of the cancer? Because it directly affect the survival. So if we see 5-year disease-free survival for all the sides of the oral cavity, be it buccal mucosa, tongue, palate, anything. So if we see the total 5-year disease-free survival after giving all the possible treatment to these patients, it is hovering somewhere to 50% in the globally. And if we see in India, it is around 40 to 45%. So this poor survival is because we are seeing 80 to 90% of the cases in the advanced stages, that is stage 3 and stage 4. So that lead to a poor survival in the patient. And so that should be our aim should be to detect the patient at the early phase to improve the survival. So what are the efforts which we can put through to improve the overall survival? Do you think, friends, only the patient's ignorance or from their part negligence is there, or we are also partly responsible, or our society is also responsible? Yes, we are also equally responsible. Friends, our society is the one who is selling and buying such tobacco products. So we should, try not to sell this product or not to buy this product. So it is directly in the patient hand. If he will not buy such, or if the government is selling the such product at the higher taxations, so it will not be easily available, or it will be very expensive for the person to buy it. But unfortunately, the tobacco industry is a huge industry, and uh, it gives employment to 38 million people, and it is a very good revenue source for the government as well. So what we can do from our side, we can do proper counseling of the patient. We should do proper screening of the patient. We should have a thorough knowledge to diagnose pre-malignant lesion conditions or any other pathologies of the oral cavity. And more so, if somebody is doing biopsy or something, uh, he should maintain the proper documentation. Before taking the biopsy, he should take the clinical photographs of the patient. He should advise necessary radiological investigations to the patient, so that he can convey that information to the person whom he is referring, so that he can plan the treatment accordingly. That will help surgeon a lot. So, to creating the awareness, my article was published in Dainik Bhaskar on this recently, 27th July 2020, where I have given a lot of information on how we can reduce the burden of oral cancer via the medium of newspaper, so that it can reach to the normal people. So if we see the main etiological factor in the oral cavity cancer, genetic is not much proven. It is mainly because of environmental factors like tobacco or tobacco related products, alcohol, any chemical carcinogens, any physical factors, like so many people ignore the sharp tooth or decayed tooth. They can also physically cause trauma to multiple times to the that region, and it may convert into the cancer. There are few viruses like human papilloma virus. They are also associated with oropharyngeal cancers. Long-standing inflammations and improper diet and nutrition that you always tell to your patient as an Ayurvedic physician. If there is a bad habits from the patient side, it can ruin even a good horoscope. So if we see briefly how these cancers develop, uh, person is taking carcinogens in the form of tobacco that will act on the DNA. It will cause binding of the DNA. So there will be an adduct formation. So during the cell cycle, there will be no division of such things, and there will be a permanent damage to DNA. And these permanent damage to the DNA will further proliferate, and it will form a new pre-neoplastic clone, and that will convert into the malignant neoplasm. All the person who is taking these products will not develop. There are so many person who come to us and tell, sir, हम तो 40-40 45-45 साल से कर रहे हैं, हमारे को तो नहीं हुआ, या ये आदमी तो कर रहा है, इसको नहीं हुआ, मैं 2 साल से कर रहा हूँ, मेरे को कैसे हो गया? तो every person's immunity is different. So there is always a capacity of cell repair in our body. So if that efficiency is gone in the body, then only it will convert into the cancer. So if we see the spectrum of oral cancer, uh, it is around 90%. It is squamous cell carcinoma in the oral cavity, and rest is verrucous carcinoma, malignant melanomas, osteosarcomas, or minor salivary gland tumors in the oral cavity. So there are various subsites of the oral or of the oral cancer, but typical Indian cancer we consider is gingivobuccal sulcus cancer, because people tend to keep tobacco pouch in that area between the tooth and between the buccal mucosa. So maximum patient tend to come with the GB sulcus cancer, and rest are tongue, floor of the mouth cancer, palate cancer. Patient can develop maxillary sinus cancer, soft palate, hard palate cancer, buccal mucosa, etc. So most of the people in the Indian population, they usually develop these precancerous lesion or condition before developing to the cancer proper, like leukoplakia, erythroplakia, oral submucous fibrosis, oral lichen planus, frictional keratosis, etc. So when do one suspect carcinoma? If there is any red patch, white patch, if there is any ulceration, if there is an oral swelling, if there is an unexplained tooth mobility which is not related to dental causes, if there is any difficulty in swallowing, pulling of the saliva, unilateral late nasal discharge that is serosanguous, which is lasting for more than 3 weeks, and if there is any unilateral discomfort in the throat for more than 4 weeks, which is not subsiding with the antibiotics, or if there is any change, hoarseness of the voice or change in the voice, or if there is any masses near the orbit or in the any part of the face, or if there is any vague ear pain which is not related with the local ear problems, that can be due to the mass in the base of tongue. So how we should evaluate these patients with the oral cancer? Always it is very important to take the history, proper history of the patient, his habits, everything, general physical examination, detailed head and neck examination. In that we need to check the primary, how it is, which all structures it is involving, how many subsites are involved. Then we need to palpate the nodes in the neck, whether till what level the disease has gone. Depending upon our examination, we prescribe radiological evaluation based upon the sites involved, like CT or MRI with contrast. And then comes our histological diagnosis. And there are various means of histological diagnosis, but always biopsy remains the gold standard. And as very well mentioned by Dr. Aditya, the psychosocial assessment of the patient, it is very important aspect of the treatment. We have to consider what is the thought process of the patient, how is his acceptance, how is the acceptance of relatives, how they will how they will accept the treatment, because sometimes the surgery might be mutilating, because if some cases, if plastic surgery doesn't work, then it is very mutilating for the patient. But they should not discourage, because the first and foremost important thing is for curing is we need to do some form of treatment which is related to that cancer. So in history, we need to take history about causative agents, like whether the patient having tobacco chewing habits since how long, what is the frequency, alcohol, everything, consumption, and other risk factors. So we need to take a detailed medical histories that will help us in the further management, patient's family history, whether there are any other people who are suffering from cancer in their family, their personal history, and clinical evaluation. So clinical evaluation, we need to assess the general condition of the patient, examination of primary and neck symptoms. Already patient may come with the symptoms of, like pain, pain in the particular region, bleeding, trismus, tooth mobility, discomfort, burning sensation, nasal discharge, weight loss, any hoarseness of the voice, dysphasia, difficulty in swallowing movement, or hearing loss. So these all symptoms patient will present. So there are different method of screening of oral cancer. So the gold standard always remain histopathological evaluation and in that biopsy is the first and foremost important thing. Until unless biopsy is cannot be done on the medical grounds, we can do FNAB or FNAC and exfoliative cytology or breast biopsy. There are clinical methods like vital staining, photodiagnosis like chemiluminescence, tissue fluorescence imaging, tissue fluorescence spectroscopy, molecular method like tumor markers or immunohistochemistries. So what is not explain all these things in the detail, but most important thing, how biopsy is performed, it is very important. Always a narrow and deep biopsy is preferable than shallow and wide biopsy. That will not give us a very good information and that will not sometimes give, proper diagnosis of the cancer and we need to unnecessarily repeat the biopsies. So normal tissue should also be taken along with the cancerous tissue to assess the site. So this is desirable. We can also perform a punch biopsy. Punch biopsy can be done in a very limited mouth opening patient also. We can use a punch forceps to take the biopsy. So what is fine needle aspiration cytology? We can use a whiteboard needle, and if the patient we cannot do open biopsy for certain problems with the malignant with the history of some medical issues, then we can do fine needle aspiration cytology. If there are neck nodes which are positive in the neck, you can aspirate the content from there. Brush biopsy, we have to roll the brush along the deeper surface so that a little bit bleeding is induced. And then the slide is prepared and stained with the PEP so that we can get an information regarding the malignant cells. So exfoliative cytology, it is only used for screening purpose, oral screening, for the mass screening of the patient. So this is toluidine blue. It is a chemical which is applied on the mucosa where more activity will be going on. It will pick up the dye there more. So it will give a very good site also where we can take the biopsy. And there are few lighting systems where tissue reflecting system where throwing the light on the tissue. If it is normal, it will uh, be visible as a blue light, and if it is abnormal, it will be looking as aceto-white. Same a device is there, Wellscope, which is used as a device for autofluorescence. If there is an autofluorescence from that site, it is a normal tissue, and if it is a dark tissue, then it will be a malignant tissue, or there is some problem in that area. If we see the oral cavity cancer is mainly, the dental people run along with these kind of cancer because their management is required in all the phases. So in the pre-treatment, what is their goal? They should eliminate the potential sources of infection. They should counsel the patient for the short and long-term complication of cancer therapy. For any preventive aspects, they should give idea to the patient. And the goals during the cancer therapy, they should treat supportive care for the oral mucositis, oral candidiasis, xerostomia, and trismus. And in the long term also, along with the management of trismus, xerostomia, and prevention of dental caries and osteoradionecrosis, they are also helpful. Sometimes people don't reach us in follow-up period, so they will be going to their dentist or any other person who has referred the case to us. So they will tell us, okay, sir, that patient has developed the recurrence. So with this brief overview, I will restrict my discussion on the case-based. This is a 28-year-old chap, but luckily this patient was very well aware of the oral cancer and he has reported very well. I have performed the biopsy that turned out to be well-differentiated squamous cell carcinoma in the right buccal mucosa. So and it was in the stage 1 stage. So you will as my slides will go on, you will see the differences of what we make when we treat patient with proper surgical procedure if we follow. So what we have done wide local excision, and along with that we have performed the extended suprahumoid neck dissection. So because once there is a cancer in the oral cavity, it tend to go into the neck nodes. So we need to even prophylactically do neck dissections in such patient. So I have performed a wide local excision, and I have done suprahumoid neck dissection, and reconstruction of that defect was done using local flaps from the buccal fat pad and the FAM flap, that is facial artery myomucosal flap. So here is one more case where there was a cancer on the right lateral border of the tongue. So I have done partial glossectomy of the tongue, and I did extended suprahumoid neck dissection. So extended suprahumoid neck dissection is the one where we remove level 1 to 4. So in suprahumoid neck dissection, I remove only level 1, 2, and 3. In the extended, we remove level 4 because there is a skip metastasis in cases of tongue carcinoma. So we tend to remove one level more in cases of tongue. And you can see if we manage these cases properly, I have given a just and horizontal incision, and that too in the neck skin crease, that these young patients can get a beautiful scar in the longer period and with minimal morbidity. So this is a patient with the left buccal mucosa and commissure cancer. So this is in stage 2 cancer. So in this, though it was abutting to the tooth, it is abutting to the tooth region and to the mandible. So we need to remove a part of mandible as a margin and the tooth surrounding tooth and the lip. So I have removed that in toto and done suprahumoid neck dissection. And you can see in this case, I have used the flap from the face, which is nasolabial flap. Though I have advised the patient to go for free radial forearm flap, which is through the hand. But since the patient was not really affordable and the free flaps are really expensive procedure to do, so he was not willing. So I need to take flap from his face itself. So you see, as T staging increases, as the patient come with the advanced stage, we need to do a more mutilative surgery. But still, after this also, you can see the results after 6 months of the surgery. So scar as on the face is hardly visible. Patient mouth opening is acceptable. Here is one more case of right lateral border of the tongue where I have done glossectomy, partial glossectomy and extended suprahumoid neck dissection. And along with that, you can see again, I put, since the patient is only 38 years old, I have done a very small incision in the neck, and I have done my procedure with the minimal invasive approach so that this young patient can get the good results. And this patient had neck nodes also positive for the cancer. So I need to send this patient for radiotherapy as well. But still you can see, and this patient was also suffering from oral submucous fibrosis along with the cancer. And he was also advised to go for surgery for oral submucous fibrosis, but he was not willing for that. So this is the photograph after 4 months of the surgery, and you can see a hardly visible scar in the neck and that in the skin crease and acceptable mouth opening. This is a patient I have operated around 4 years back, and this is a follow-up picture of the patient after 3 years. See the mouth opening, beautiful mouth opening, symmetrical face, and I have performed marginal mandibulectomy in this case, and I have performed the same nasolabial flap from the neck in the face fold, nasolabial fold, and you can hardly see the scar after 2 years in the neck. This is the patient. Here I will like to tell how the recent advances of the microvascular surgery is there, and how in the advanced cases also we are able to give a very good healthy quality of life to the patient so that you know they can live a very good quality of life. This is a patient where a typical Indian cancer, oral GB sulcus cancer, which was invading into the mandible. So how we does it, I plan the treatment on the computer itself via the 3D printing, like where to where we need to cut, we need to resect the mandible segmental fashion in this way. And then I have planned a free fibula flap from the leg, so that we can, after removing the part of mandible, we can put the bone as well as soft tissue here, so that we can properly reconstruct the patient so that he can live a very good, healthy life afterwards. So this is the resection. This is the harvested fibula along with the skin and the muscle, FHL muscle, and along with that the vessels, which are the peroneal vessels, which we use in these flaps, and we anastomose these vessels with the neck vessels, and usually we prefer to do it with the facial artery and internal jugular vein. So this, you can see the immediate in the intraoperative picture. Since we have resected the mandible from here, but you can see the contour of the patient on table. He has maintained a very good contour on table, and you can see the worms view also and the side view. This is my patient photograph after 6 months, and you can see a very symmetrical face and with minimal scar. This is the mouth opening. So, and even on this, the advantage of this fibula flap or bony flap is if we can put dental implants over it, so that we can give tooth as well to the patient. So that will be complete rehabilitation for the patient. So we can give a very good chewing efficiency, everything. So that was the person which you have seen in the previous slide was the nephew, and this is the same nephew's uncle. I have operated this patient around 5 years back, and see, after having the getting the good results, he when the cancer developed in his own nephew, so he reported to me, sir, like you please perform same kind of surgery, because I think he will also require. Though we are very much not affordable, we wanted to go to government hospital for treatment, but seeing your treatment, we came to you so that we can get a very good treatment. So you can see here, segmental dissection of the mandible was done. Fibula flapor was harvested from the leg, and the skin grafting was done to cover the donor site. This is the patient's 2-year photograph. You can see, you can hardly make out whether the patient has undergone such an extensive surgery. And this patient is still coming to me after 5 years of follow-up. And you can see a very good, beautiful mouth opening. So he can chew anything, he can eat anything. This is one more patient with the retromolar trigone cancer with oral submucous fibrosis. The mouth opening is very, very limited. So I have explained this patient that I will be doing cancer surgery. Along with that, I will treat you for oral submucous fibrosis, so that, because once we will put fibula flap, you will go for radiotherapy, your mouth opening will further restrict, and you will not be able to open the mouth. So doing such a good surgery will not help you. So you will be totally dependent upon the soft diet. So I decided to do oral submucous fibrosis surgery also for this patient. And for that, what we do is we do bilateral coronoidectomy. We cut the fibers from both the end. Since the other side there was a cancer, so I have already resected the mandible, and the other side I have done the fibrotomy and coronoidectomy and put the nasolabial flap on the contralateral side, and the other side I have done free fibula flap. So you can see the result of the patient in the immediate post-operative period after 12 days, and a very good mouth opening. And the same patient, when it reported after radiotherapy, you can see a very good result in terms of facial symmetry, dental occlusion, and everything. He can eat each and everything. Though this is not a cancer patient, but this is a very, very interesting case. That's why I have put here. This patient is actually suffering from mucormycosis. So I have done secondary reconstruction for him. So both the maxillas was involved in the mucor. So we have done subtotal maxillectomy bilaterally. And since this patient was suffering from polio of both the legs, so ideal flap which was required for this case was fibula, so that we can give a proper bony reconstruction to his, and we can do dental rehabilitation. But since there was a polio in both the legs, we could not harvest because there is very uncertainty of the vessels, because the vessels we will get from that area will not be a very good quality. So I have done a bilateral temporalis flap, taking from temporalis muscle from the scalp, and the full coverage to the pellet was given, and still cosmetic result, and patient is able to at least manage with the soft diet, though he is not able to take hard food stuff because bony reconstruction is not done, but he can very well manage with the soft diet, and he is very happy with that. So this is a patient, not only the cancers, there are sometimes the patient come with the various pathologies of the mandible, like cyst or any bony tumor. So this is a case of recurrent KCOT. So this patient has got operated 2 times back before somewhere, and the same thing recurred. What they were doing, they were just scooping out the lesion, and it was not healing. So so bony formation was not happening. So what I did a segmental resection or distal mandibulectomy, and removed the lesion. In total, you can see a very small incision in the neck. Through this only I approach the thing, and I removed all the disease portion. We have taken the fibula from the leg and did the reconstruction, and this you can see the beautiful result. And I was telling, I have done the dental rehabilitation also for this patient through the implants. So we have given a very good results. Since this patient was not suffering for the cancer, so dental rehabilitation was a bit early, and this patient is extremely happy. This is one more patient with the carcinoma in the mandible anterior alveolus. This is a very challenging case scenarios when it develops, because all the tongue attachments are there to the medial part of the mandible. We know it attached on the genial tubercles. We all have read the anatomy. So when we cut the mandible from both the segments, and it become very much essential to reconstruct it with the a good bony support. So in this also you can see the tongue is taken out through the pull through approach, and everything from the anterior part, this much part of the mandible is being removed along with the neck dissections. So after that we have harvested the fibula, and we have done the insetting, and you can see the immediate on table results of the patient. So now this is one more case where it is involving almost half of the tongue, and in this case, for giving the proper margin, I need to remove almost 60% of the patient's anterior two-third, 65 to 60 to 65% of the oral anterior two-third of the tongue. So after removing that and performing supraomoid neck dissection, we did reconstruction with anterolateral thigh free flap. We harvested this flap from the thigh based on descending branch of circumflex femoral artery, and then later it was anastomosed with the neck vessels. And you can see beautiful reconstruction of the tongue with starting of mucosalization also. So that disease part also, after removal, when it was covered with the flap, it started looking like tongue. And I will show this patient's video also how her speech is. And this is the one more patient which was belonging from my own native place, for whom I have done the reconstruction of the tongue, which got coverage in the newspaper around 3 years back. So this is a patient which is having carcinoma of right cheek. You can see I am explaining all the cases because to show all the subsides of the oral cavity, what all types, variety of cases we can get. So this patient is having the ulcer is perforated to the skin also. So this is an advanced stage. So it is stage 4 cancer. The previous cases were what 2 or 3 cases also I have shown was stage 4. So we have done the composite resection of the tumor along with the tumor with the buccal mucosa, the part of the commissure, and the skin as well. So we decided to reconstruct this defect with the 2 flaps. I have used the cervical flap from the neck to cover the outside so that even we can get a good hair growth hair growth on the cheek, because if we use the radial forearm also outside, that is depend upon the individual preference. Some people use bipedal radial forearm for outer and inner lining, but I prefer to use the cheek outer cervical flap, so that we that hair growth that will look more symmetrical, and patient will have beard also later on. That I will show in upcoming pictures. So we have harvested radial forearm free flap from the hand. So it is based on the radial artery, and we along with that we take cephalic vein also, and vena commitans. This is the patient's photo after around 6 months. A beard growth over this portion also. This is another case of this a case of right lateral border of the tongue with extensive involvement of the tongue. I required to do hemiglossectomy in this case, and after hemiglossectomy and neck dissection, I have performed radial forearm free flap, same like I showed before, and you can see here how minute these vessels are. We need to anastomose these vessels under microscopic magnifications. So these kind of surgery require a lot of expertise to perform to give a very good and beautiful reconstruction. And I am very, very much thankful to my teacher who has taught me microvascular reconstruction. And I can proudly say it belonged from Calcutta for Sharma sir. He belonged from your place. And I can proudly say I am student of Dr. Saidul Islam sir. And you can see here after this is the reconstruction, immediate reconstruction in the OT, and you can see the patient in ward, and you can see here the mucosalization of the tongue has already taken place. You can see in this video how the speech is. Video not audible. Video play नहीं हो रहा है. Video नहीं हो रहा play. Sorry, actually video is not playing through. So otherwise I would have shown you how beautifully she can speak even after losing half of her tongue. Very good conversation. She can tell all the consonants very well. Very good deglutination and everything. So there are a few scenarios when the patient are very poor and where we cannot give fibula free flap reconstruction in such cases. So in that cases, what we do, we put a titanium plate, and along with that we use pectoralis major mycutaneous pedicle flap from the chest. This is considered as workhorse flap in head and neck reconstruction. So over the plate, we have put so we can give an acceptable result to the patient at a very affordable price. So this is a case of advanced recurrent carcinoma of the right cheek, and that too after post radiation and chemotherapy perforating from here. So I need to perform an extensive surgery. This patient was denied for surgery from lot of institutes, and then patient reported to me. I have explained him the prognosis. Since this disease is very, very extensive, so prognosis will be very, very poor for this case. But still patient wanted to get rid of this outside fungating growth. Said, you give me a proper coverage so that at least I can till whatever time I need, I can live peacefully. So with that, I have done resected this extensively. You can see a huge defect, and since this patient was previously operated, reconstruction with the free flap was little risky because 50% chances of the flap failure, and there was also financial constraints from the patient side. So we have to explain when we are doing about the flap failure also. There are 5% chances of flap failure, so that some patients doesn't agree. So in that cases, we have to somewhat compromise on the reconstruction and select some loco-regional flaps. So in this flap, for the very first time devised or have taken such a huge pectoralis major flap uh, through the chest, which is very, very much equivalent to the what I would have harvested from his thigh, from the anterolateral thigh. So you can see the coverage of the defect on table. And here, this part I have covered, though we were not able to close it primarily. So later I have skin grafted this defect. So this is the sort of reconstruction patient has got into for such a huge defect. This is a case of left maxillary alveolus and palate. So there I need to perform subtotal maxillectomy, and neck dissection need to be performed, and because we have planned for anterolateral thigh free flap. So, and it was reconstructed with the anterolateral thigh free flap. And later I have given the dental rehabilitation also to the patient. You can see a beautiful smile of the patient showing all his teeth and getting obturated. The patient looks extremely happy with the treatment. So this is the patient. I don't have intraoperative picture of this patient. In this, total lower lip was involved with the tumor. So I need to resect the total lip, and I have reconstructed this lip again with the bilateral nasolabial flap. This patient also, my first plan of choice was radial forearm free flap, but the patient was not very much affordable. So I planned this flap. And this is the case where the tongue was extensively involving the contralateral side. So I need to remove the total tongue. So total glossectomy need to be done. Bilateral neck dissection was performed, and this defect was reconstructed with PMMC flap harvested from the chest. You can see the formation of the tip here. So along with the cancer, I'd like to put a few cases of oral submucous fibrosis. This patient has came to me from Orissa, and he was having a less than one finger mouth opening, very much difficulty in opening the mouth, and his life was debilitated because of submucous fibrosis. He was unable to eat properly. So I have done the oral submucous fibrosis surgery. On table, you can see I have achieved a mouth opening of 5 centimeter. I have performed bilateral coronoidectomy, fibrotomy, and bilateral island nasolabial flap. And this is on table result. I have put the cosmetic suture so that it is hardly visible on the face later on. This is the patient's mouth opening, 2-finger mouth opening only after 1.5 months. And this is the patient 3-finger mouth opening after around 6 months. This is my another patient which reported me after 1 year for follow-up. You can see the beautiful mouth opening and a very good scar on the face from the nasolabial fold. Sorry, my videos are not playing through. And at the end, I will like to give a few clinical tips for managing the patient. So the screening is the very, very most important tool for detecting the oral cancer patient at the early stages. One should not neglect the sharp broken tooth or decayed tooth. They should be timely, they should be treated. Oral hygiene play a very, very important role. And as a clinician, it is our duty to spread the awareness so that we can treat these kind of cancers at the very early stage, and we can get a very good cure rates. Though we have a very good cure rates, even we are giving a very good and beautiful results to our stage 4 patient also with very good quality of life. But obviously the results are not as great as in the stage 1 and the stage 2 cancer. So along with that, the cancer patient treatment doesn't stop at the surgery. The patient need to go for further treatments like in the form of radiotherapy, chemotherapy, and additionally the patient should also, even I advise some dietary modification for the patient. I always, like Dr. Aditya told, I always prescribe my patient to take lot of foodstuffs which contains lycopenes, beta carotenoids like carrot, beetroot, and lycopene containing like tomato, and they should take turmeric, the haldi. It is well known, and from our rishi munis also. And if I tell, we are working as surgeons now, but father of surgery is nobody else other than our great says Shushruta. So he has taught us all these principles of the surgery and how to do it. So if we go back and see, so the first microvascular surgery was performed by, I think, Shiva. Lord Shiva has performed it on Ganeshji because his whole head was amputated and he has put the head of uh, uh, an elephant. So how it is possible? It is possible with the microsurgery only, because that vessel's anastomosis was given so that that head can be stabilized on that part. So it's all ancient, and it is this the treatment is not a one person's cup of tea. We should all come in a team to give a best results to our patients. And after finishing all these procedures, we should always advise the patient to be in close follow-up. I always tell my patients who are willing to take some Ayurvedic supplements, I always guide them to take an opinion from the person who is taking, who is actually giving or working in the field of Ayurvedic oncology. So I usually refer my so many patients to Dr. Aditya for guidance. And thank you so much, everyone, for patients listening. This is my contact details, and if you have any queries or questions, please always feel to contact me. Thank you so much for your kind attention.
Thank you, Dr. Kalpesh. Very nice presentation. Very nice presentation. Very nice presentation. And with a practical clinical experience, you have shared very nice to all the clinicians.
वाह, बहुत अच्छा, excellent sir.
Thank
क्या
you so
scientific
much, sir.
information आपने share की है. Excellent,
thank you so
excellent, Dr. Kalpesh.
And I am glad to say, sir, I was there in
Am I
Calcutta
audible
for.
to all?
Yes, sir. And I am very glad to say that I was staying in Calcutta after my training from the Kidwai Memorial Institute of
Hello?
Oncology. Sir, am I audible, sir? Am I audible, sir?
Yes, you are audible, Dr. Kalpesh. You are audible.
Yeah. So, sir, I can proudly say
Hello?
that.
Dr. Aditya?
Yes, sir. I can listen.
Oh, sorry.
Sir, might be you are muted.
बहुत बहुत धन्यवाद. Any question from audience, please?
Sir, it is a very wonderful presentation, sir. I am Dr. Vivek from Bangalore.
Yes.
I just wanted to ask, in a stage, whatever, after doing a biopsy, sir, within how many days it will spread and progress? For example, it may be stage 1 or stage 2 cancer. So within how many days it will go to the further stages?
So
for
Dr.
example,
Kalpesh,
it is
please.
squamous cell carcinoma.
Yeah. Dr. Vivek, is this question directed to me?
Yes, sir. Yes, sir.
Yeah. Thank you, Dr. Vivek, for wonderful question. So, Dr. Vivek, actually, we recommend it is always like after performing the biopsy, we should do the surgery as soon as possible. But in our Indian scenario, people like to take multiple consultation with the other. They discuss with the family a lot, and they will like to take a financial support. So somehow they delay the treatment. But as time pass on, we cannot comment exactly after how many days it will spread into which stage. But yeah, as time pass on, the chances of spreading the tumor is always there. So if I always tell two of my patient to report for the treatment at the earliest. In the very early stage, when the patient in the early stage, like stage 1 disease, they should be treated as soon as possible, because if we treat the patient in the stage 1, we will be able to deliver a very good results. So in the oral cavity cancer, the cure rate is as good as 97% if we treat patient in stage 1. And I tell always in the advanced stages, if they are planning to get surgery done, I tell them to get operated as soon as possible, because after some time will be lost that case might become, inoperable. It will not be feasible to operate them later.
Sir, Dr. Kalpesh sir, so buccal mucosa with mandible erosion, so what will be the
Yes.
survival rate after surgery?
Yeah. So in the buccal mucosa, if we see the chances of local recurrence means disease getting coming to that proper site is more compared to the neck failure or distinct failure. Like metastasis of buccal mucosa cancer into the distinct sites and failure in the neck is little lesser, but local failure is, because if we see in the buccal mucosa, when we treat on the basis of compartment. In the oncological principle, we follow at least 1 centimeter clear margins all along, which is not possible in the buccal mucosa cancer. In When it is, we go as per compartment. Like if buccinator muscle is not involved, we go and remove till the subacute level and from the depth. So we might not get 1 centimeter clear margins in the depth. So some of the country like there is this Japanese study. They are coming up with the composite dissection even in the stage 1 cases for the buccal mucosa. So what they are doing, they are removing a part of the skin also along with that, and this is still under trial. That whether removing the skin will serve the purpose, we can get the better cure rates. So if we consider the cure rates, so for the stage 1 and stage 2 buccal mucosa cancer, the cure rate is pretty good. Stage 1 cancer, it is up to 85%. For the stage 2, it is as good as 70 to 75%. For the advanced stage, it is somewhere between 40 to 50%.
Sir, actually, I am a associate professor in Sri Ayurveda College in Bangalore. So we have started a oncology unit, and I am in oncology since 5 years. So we
Oh,
have seen
great,
many
great, great.
cases recurring within 2 years or 1.5 years. So
Yes,
recurrence
yes,
is there. So
yes,
is
yes.
there that surgery you talk in terms of cure or in terms of survival rate?
No, for any sort of cancer, if we are talking, first of all, cancer is only curable in the early stages. Let me clear. It is not at all curable at the advanced stages. We always talk in figures. Like if we perform procedure at the stage 4, say 40 to 50% will be disease free after 5 years. So we always talk in terms of 5-year disease-free survival. How many of my patients are surviving after treatment and they are disease-free after 5 years with my treatment? So we always talk in that. Disease may recur after 7 years, 8 years also, because the patient has chewed the tobacco or its ill effect are seen in all the part of the oral cavity. He might has developed cancer today in the buccal mucosa. He might develop cancer in the tongue or in the palate someday, because the effect of the cancer carcinogens is everywhere. So he might develop cancer, and that we called as a second primary. He might develop a second primary later on. But for that, patient has to maintain a very good healthy lifestyle. Diet is very important. They should not start, smoking or again this thing. And you see our environment nowadays, it is full of radiation, as very well explained by Dr. Aditya. Radiation is all around. So this is still under study. Who knows?
Yeah.
There is still not much research like whether these mobile radiations or whether they are harmful to even oral cavity or also, who knows that?
Yeah, yeah.
Still that research come, we cannot say, because there are so many patients who have no habits, but still they develop cancer. So how they are developing cancer? There's some problem in the genome as well. There is a mutations in the cell is not behaving properly. So you are right. There are so many people who might come with the recurrence, but it always depend upon 3 factors. I say patient factor. So how that patient cancer's behavior is, that is very, very important. So it is always different in all different patients. So we talk in terms of if there is a perineural invasion, means if the cancer is running into the nerves, if there is any lymphovascular emboli, whether it is gone into the lymphatics or into the vessels. So these cancers present with the poor prognosis. So is there any extracapsular spread in the lymph nodes? So these are all the factors. How many lymph nodes are positive? The single most important factor is the spread of the disease from oral cavity into the neck. Straightforward, 50% survival reduces once the disease has spread into the neck, because it has jumped into the next level. Now it might spread into the other part of the body also. So that's why I always stress on the staging. So the patient should be treated at the very, very early stage. If we will treat all our patients started coming in the early stages, I can bet you we will have a very, very good cure rates, up to 70 to 80% cure rates in these cancers. And oral cavity cancer is, must say, present with a very good, results. Unlike stomach cancers, GI cancers are really, really very bad sometimes.
Yes, sir. Sir, is biopsy will spread the cancer, or it will turn into
No. Yeah, that's right. This is the very, very important. No, see, this is very, very important thing. And, this is dilemma even in our clinicians also. There are so many my Ayurvedic friends or practitioners who do refer cases to me. So they also tell, sir, biopsy करने से spread बढ़ जाएगा? Yeah, it will be a little faster, or no, it is never like that. But yes, if the tumor is in the bone, and if some dentist, without knowing, if we extract the tooth, the disease will further progress, because it has broken the boundary, because tooth itself is a barrier for tumor to invade. So if the cancer is there in the buccal mucosa or GB sulcus, and the tooth is mobile, and dentist carelessly, if he has removed the tooth, because he will also be unaware most of the time, so he will remove the tooth, so that will further spread the cancer faster. But biopsy definitely will not. But we always recommend after biopsy, it should be, treat as soon as possible.
Yes, sir. Sir, one more patient is there. Ameloblastoma case is there. So what is the prognosis, sir, after surgery?
100%. In ameloblastoma, I will say, in my 10 years of experience, not a single case has failed in my hand. Okay. And I can give 100% writing in my with the hand, unless it is a malignant ameloblastoma.
No, sir, it's a benign. Yeah. Sir, I am treating.
No, what I am telling, bony ameloblastoma is a benign condition, but it is a very aggressive. It is a very aggressive bone tumor which invades very fast. But there is one more variant, malignant ameloblastoma. So where there is a malignant name along with that, nobody can give a guarantee. But ameloblastoma, if you give very good margins of cut, bony cuts, you can get a very, very good results. One of the patients I have posted, he was having sort of ameloblastoma. I had a very good series of my ameloblastoma patient where I have done mandible resections, and I have given free fibula flap reconstruction. They are doing extremely well.
Sir, I am treating this ameloblastoma with Ayurveda, Panchakarma treatment, and other oral medicines. It has maintained since 5 years. Since 5 years. Okay. So I'll convince the patient and I'll refer to you so that he can get rid of the problem.
Yeah. Dr. Vivek, one thing we need to understand is ameloblastoma is one of the entity, which might not, in all the cases, it will not progress very fast, because that case has developed over a period of years. So it is not like a cancer, it will spread rampantly, and it is not life-threatening also. So it is a benign condition. So sometimes it might not, progress also faster. So, but if it will, started progressing, it will give a very debilitating results, because patient has to go for more amount of resection of the bone. The bone will be damaged, and we need to do a more sort of bony reconstruction, longer length.
Sir, one more last question. If it is any cancerous lesion in a very initial stage, can we try with some of the anti-cancerous herbal medicines with Ayurveda? So what is your opinion? Because Sushruta ने बहुत बताया है व्रणारोपण बोल के. He has told so many n number of plants and he has told 60 types of management of non-healing ulcers. So can these non-healing ulcers be tried with some medications? Can we collaborate or integrate allopathy and Ayurveda so that we can give a good result to the patients?
As my friend Aditya has told, see, I don't know long back how our great Shushrata used to treat such cases with the surgery in the initial stages or with these Ayurvedic remedies. I don't know because I have not have a very good knowledge in the Ayurvedic medicine. So it is very difficult for me to answer this question. So until unless we do, a randomized control trial, so it is very difficult to say whether these people can get cure with the Ayurvedic medicine alone or not. But yes, I do tell home remedies or some Ayurvedic treatment sort of thing, which I will not advise, but I will refer them to to Ayurvedic oncologist so that they can give a better opinion to the patient, because I know certain things like haldi is beneficial and this is beneficial and this is in blah blah cancer, which medicine is useful, which will give better results, that I don't know. So I usually tell our colleagues, those people who are interested in Ayurvedic treatment also. So I usually prefer to in the oral cavity cancer, I always prefer to operate first if it is operable. That give a very good cure rates. We have seen so many patients who has undergone radiotherapy or chemotherapy first, and then later they reported for surgery. So they usually don't do that better as compared to the patient who go for upfront surgery followed by chemo radiation as per requirement. Yes, there is definitely role of Ayurvedic medicine also, but as a supportive mode. As far as I am concerned, I may be wrong because I have no idea about it. So this
Some
last
research
question will
should
be,
happen.
yeah,
Some
it will
research should
be
happen.
come with research.
And also it should not be delay for the surgery, if we are trying
Yes.
with some
So
medication, and it should
if we
not
are
be delay.
trying with some Ayurvedic medicine and all, so and if it is not responding, and then patient will upstage, that
Yeah.
stage one will jump into stage 2 and 3. That
Yes.
will definitely affect the overall survival of the patient.
Thank you, sir. Thank you very much. Thank you, Aditya.
Most welcome,
Dr.
most
Sir.
welcome, and dear,
Thank you,
I am
Dr.
very
Vivek.
happy.
Thank
Thank
I'm
you.
very happy that you were so interactive and you have asked lot of questions. So
Sir, we have started a cancer unit in our college, Sri Ayurveda College,
okay.
and I am the
Okay.
senior Ayurvedic oncologist there, and we have treated more
Okay.
than 1,200 cases, and many
Oh,
are
great,
supportive
great.
and many are main line of treatment we are handling. And thank you for
Okay, okay.
Zandu people for organizing such a wonderful seminar, both from Dr. Aditya sir and from Dr.
And
Kalpesh sir. It was very informative and useful. Thank you very much.
and when I feel people who are somewhere related with me with the as you told, you are from Bangalore. I was also there in Bangalore, and I was almost 12 years I have spent in the Karnataka. So
Oh.
you will be thinking I